Hello and welcome to Chapter 4 in Alternate Care Systems. Chapter 4, we're going to be covering Managed Care. We're going to slip through these learning objective slides and get to our first slide on slide number 8. And we're going to do our introduction to the setting and the plans of our managed care organization. So managed care is the provision of comprehensive healthcare services coordinated by a third party with the goal of improving an individual's access to quality medical services and preventative care while increasing efficiency and cost effectiveness. It's based on a preventative model that managed care aims to ensure reduced utilization of costly tertiary healthcare services through effective coordination of care for individuals who are enrolled in the program. This is accomplished by promoting preventative services and medication compliance and incorporating predictive data algorithms to identify at-risk patients prior to the occurrence of an acute healthcare crisis or event. This coordinated effort to reduce emergency services utilization and decrease poor patient outcomes ultimately results in more efficient use of the healthcare provider resources and reduced cost. So the major types of managed care organizations are health maintenance organizations, provider organizations, point of service organizations, managed indemnity plans, and then we're going to talk about some consumer-directed health plans and integrated delivery systems. Now, let's start first with health maintenance organizations on page 120 in the textbook. So a health maintenance organization is a business entity that either arranges for or provides health services to an enrolled population. Individuals enroll in the plan and are obligated to pay a fixed sum of money called a premium on a monthly or annual basis. Theoretically, prepayment of a premium serves as an incentive for the individual member to participate in preventative care services and to seek treatment before a condition is exacerbated. It also serves as an incentive for the caregiver to provide care with the greatest efficiency and the best possible outcome because the amount of reimbursement for services rendered is fixed. HMOs are found in a variety of different forms, each named by its organizational structure. But regardless of the structure, there's 3 characteristics it has to have for it to call itself an HMO. Number 1, an organized system for providing health care or otherwise assuring health care delivery in a geographic area. Number 2, an agreed upon set of basic and supplemental health maintenance and treatment services. And number 3, a voluntary enrolled group of people. So those 3 things have to be there for it to be an HMO. Now we have different models of HMOs. Our first model is the staff model. The staff model HMO is the most tightly organized HMO structure. The HMO entity owns the facilities and employs the healthcare providers to which the covered individual has access. Healthcare providers employed by the HMO are paid fixed salaries and are obligated contractually not to treat patients outside of the HMO network. Because profits earned through this model go directly to the HMO rather than to the individual healthcare providers, physicians have no financial incentive to perform unnecessary diagnostic tests or procedures. The staff model is the only model in which the HMO actually owns the facilities where the care is provided. Example of a staff model HMO is the Harvard Pilgrim Health Plan, which operates in Massachusetts, Maine, and New Hampshire. The staff model HMO structure fell out of favor in the 1990s, and most plans have evolved into another model. Our second model is going to be the group model. Unlike the staff model, the group model operates on a contractual basis with healthcare provider medical groups and facilities that provide services to members. The HMO has an exclusive contract with a multi-specialty medical group that provides all physician services and separate contracts with other facilities necessary to provide comprehensive care. A few group model HMOs are still active, including the well-known Kaiser Foundation Health Plan, in which the Permanente Medical Group employs nearly 175,000 individuals who provide medical services for an estimated 9.1 million members. Our third model is the network model. It is a more expansive model than the group model, and contracts with more than one physician group, hospital, and other facilities to provide a comprehensive healthcare package. The healthcare providers may share in some of the profit or loss of the HMO according to contract terms, but are not required to provide care only to the patients of a certain HMO. The HMO portion of their business may vary from high to low participation. This model is often popular for plans that cover an expansive geographic area or serve rural populations. Our next model is the Independent Practice Association, or the IPA model. It was developed primarily as a way for the solo practice physician to participate in the managed care market. This model has two varieties: the physician-initiated and the insurance entity-initiated. In the model initiated by physicians, the HMO is formed by the physicians who are placing their own resources as the startup funds. The HMO contracts with each physician and the other facilities necessary to make up the HMO. In this variety of IPA, the physicians are at high risk for the resources they use to back the HMO. They also may purchase large amounts of reinsurance or stop-loss insurance to provide insurance after expenses of a given amount have been paid per enrollee, such as after $50,000 or $100,000 per enrollee has been paid per year. Insurance entities have also developed IPA model HMOs because of their ease of development. A comprehensive group of providers and facilities plus financial resources are the only ingredients necessary to develop an IPA model, readily available through most insurers. Either of these IPA models provides a wide choice of physicians from which the enrollees may choose. Financial viability has been difficult to achieve, however, as the independent physicians have little incentive to change their practice patterns, which are necessary to maintain profitability. And then our last one is the mixed model. The mixed model HMO operates within two or more different types of organizational structures to provide flexibility to members, diversity of income to the HMO, and attractive pricing to the employers. Each HMO organization evolved over time in an effort to increase profitability and maintain compliance with regulatory legislation. Through these changes, along with mergers and acquisitions, the mixed model became more prevalent. All right, still on page 122 in the text, we're going to talk about preferred provider organizations. Any aspect of a managed care program that is left to the member to decide can be difficult to predict or control. Managed care entities have a vested interest in having participants receive care from providers who can perform a procedure or provide a service in the most cost-effective manner. In an effort to guide enrollees to more cost-effective providers, the insurance industry developed the Preferred Provider Organization. Providers that participate in the PPO agree to provide services to PPO patients at a discounted rate in return for the promise of a higher volume of patients. Therefore, while the profit margin for each individual patient may be less for the provider, the increased volume of patients creates an environment for overall profitability. Members of a PPO network pay little or no out-of-pocket expenses when they obtain care from specific providers, whereas members who use other providers pay significantly higher portions of the provider's charges. Although the patient is not limited to a certain list of providers, there is a strong financial incentive to choose providers that are included in the PPO. The success of a PPO depends on the organization's ability to maintain an extensive provider network. And an example of a PPO model that exists in many states is the Blue Cross Blue Shield plan. All right, moving down to point of service plans on 123. A point of service plan is a hybrid of the HMO and the PPO models. An individual enrolled in the PPO plan pays a premium, and the care is managed by a primary care provider similar to an HMO. Unlike an HMO, however, the member still can obtain care from a provider outside of the preferred network. The coverage for services rendered by an out-of-network provider is reimbursed at a lesser rate in keeping with the PPO model. The remaining charges and increased copays resulting from receiving services from a provider outside of the preferred group are the responsibility of the insured. By enrolling in a point-of-service plan, members choose the type of provider to use and how much out-of-pocket expense they're willing to pay in return for that ability to choose. Examples of point-of-service model insurance plans can be found in every state, offered by companies such as United Healthcare, Aetna, and many others. All right, and our last one is our managed indemnity plans. So the industry term for traditional health insurance is an indemnity insurance, in which the insured patient is reimbursed for expenses after receiving the care. The traditional insurance often has deductible and co-insurance responsibilities for the insured. A deductible is the amount that the member must pay out of pocket each year before the insurance plan will make payments to providers. Co-insurance is the portion of the cost for which the member has financial responsibility, usually based on a fixed percentage. The co-insurance becomes effective for expenses above the deductible amount. For example, a patient who received care for a broken leg will be responsible for paying the $1,000 deductible. After the initial $1,000 is paid to the healthcare provider, the insurance plan will pay 80% of the provider's charges, and the patient will pay 20% of the provider's charges. Although traditional indemnity insurance places financial responsibility on the members, it also gives them total freedom to use any provider of care they wish at whatever price. It is in the patient's best financial interest to avoid costly medical bills for acute or emergent care by obtaining preventative care and wellness screenings. The healthcare provider, however, is not incentivized to provide only medical necessary or cost-effective care, as the insurance plan and the member will be responsible for any cost incurred. Managed indemnity plans were created to provide members with the freedom to choose their healthcare provider and also to control premium levels while reducing healthcare costs for the insurance company. The managed indemnity plans operate in a manner similar to traditional insurance plans, with the addition of cost control measures. The most common cost control measure included in these plans are pre-authorization of expensive tests, surgical procedures, inpatient hospitalizations, and elective procedures, with the assumption that many of these may be medically necessary. Now we're going down to our consumer-directed health plans. Consumer-directed health plans arose out of the employer's need to curtail the double-digit premium increases they were experiencing every year. Another contributing factor to the increased interest in these types of plans is the frustration of physicians and consumers concerning the restrictions and complexity of managed care. These plans are appealing because consumers have flexibility in managing their own care. Of course, a price is associated with this flexibility, an increased out-of-pocket cost. These types of plans are not managed care plans because they contain no provisions to manage the patient's care. Rather, they give consumers control of routine health decisions and provide them with additional methods of reimbursing their healthcare expenses. So the first one is a flexible spending account, or a FSA. It's a plan set up by an employee through an employer to cover healthcare costs. The employee cannot withdraw this money from this account for anything other than healthcare. The amount deposited into the account is predetermined by the employee on a pay period basis. It is pre-tax, and any amount left in the account at the end of the benefit year is retained by the employer, and it creates a use it or lose it incentive for the patient. This type of plan is used to supplement generous benefit plans by paying low co-payments and deductibles. Then you have an HRA, a health reimbursement arrangement. This is a mechanism by which an employer funds an account for its employees to pay for otherwise unreimbursed healthcare expenses. The employer makes tax-deductible contributions into the account. Funds withdrawn by the employee to pay for health care are also tax-exempt for the employee. Employees cannot cash out the balance of the account when they leave employment, but some employers may allow them to roll the account over into retirement. And our last one, these are health savings accounts. It was created as part of the Medicare Modernization Act, and it permits individuals and families who purchase high-deductible health insurance coverage to contribute to the account. These contributions then can be used to pay for costs associated with health care, including those that are applied to their deductible. Consumers who have coverage through an HSA cannot purchase supplemental insurance to cover costs incurred until the deductible is reached. All right, so what kind of patients do we have in managed care? Patients within a managed care organization are referred to as members. They have chosen a particular health plan, usually for a period of 1 year, and become members of the organization for that period of time. Some plans also refer to members as subscribers if they are the primary recipients of the insurance benefit, and as dependents if they are a spouse or a child of the primary recipient. Families or insured units also are referred to as contracts because the primary recipient makes the insurance decision for the entire family. If the subscriber of the insurance makes the decision to change managed care plans, the contract is lost to another managed care organization. Managed care organizations also refer to the number of individuals holding coverage with their company as the number of covered lives. All right, so let's talk about our types of caregivers. So caregivers that are encountered in managed care are the traditional caregivers mentioned throughout this whole textbook. These caregivers provide illness-related care. In addition, managed care uses health educators to educate patients in preventative measures that can help them retain good health, and case managers to administer disease management and chronic illness programs. So for the illness side, the primary care component of managed care uses physician extenders or mid-level providers to provide illness-related care more than do most other settings. These are your physician assistants and your nurse practitioners. They both assist primary care physicians by performing preventative services such as patient teaching and routine physical exams, and by performing assessments of acute but non-life-threatening conditions for the physician. PAs and NPs are trained to perform tasks that otherwise might be completed by a physician but do not require the same level of education. Now, this is important, so remember this. Physician assistants must practice under the direction of a physician and have their documentation reviewed and countersigned by the physician. Nurse practitioners are licensed, registered nurses who have received master's level training in areas of specialty such as adult, family, and pediatric practice. Nurse practitioners can work independent of a physician, but most frequently work as part of a team of primary care practitioners. So basically what I just said is if you are a physician assistant and you're working in a physician office, you can treat a patient, but the physician has to go back and review all of your documentation and has to sign off on that. If you're a nurse practitioner working in a physician's clinic, you can treat that patient independently. You don't have to have sign off from your physician. So that's the difference between a PA and a nurse practitioner when you're talking about coverage in like a physician office. All right, so let's drop down to wellness. Preventative care and wellness are a central focus of a health maintenance organization and most managed care organizations. Wellness coordinators or health educators are used in health plans to assist primary care providers in this portion of the mission. No formal education preparation is specifically required for the role of health educator. Other health professionals who enjoy the teaching portion of the healthcare fill this role. Nurses and dietitians function in a preventative role in managed care. Some organizations also may employ an exercise physiologist or physical therapist for cardiopulmonary rehabilitation and strengthening of members. A frequent role of the health educator is to teach chronic disease management for conditions such as asthma and diabetes. Specialized nurse educators extend the care provided by primary providers when they teach prenatal classes or write educational material for the members. All right, so we're going to cut off here, and we're going to pick up in our next lecture on page 127 with regulatory issues.